Hi everybody, my name is Dr. Kyan Lynch. I use he, him, his for my pronouns. I am a medical doctor, I'm a bioethicist, and I'm also a proud queer trans man. And I'm here today to give a little bit of information about transgender health and also answer the questions that you have. So before we get too far in, I want to make sure that we're being very clear about the terms that we're using, and so I'm going to take a moment to explain a few. So we've got three different concepts that we really need to pay attention to. We've got gender identity, sex assigned at birth, and then sexual orientation or sexuality. So to start with gender identity is essentially how you identify as a person. It's your self-concept of your own gender. So how do you feel internally? Do you feel like a man? Do you feel like a woman? Do you feel like both, like neither, like something else entirely? All of those options are valid, and all of those identities have nothing to do with body parts. They are entirely dependent on how you feel inside, how you view yourself internally. And then the second concept is sex assigned at birth. And this concept is really useful. It's really well named because it literally is the sex that was assigned to you at birth. So when you were born, a physician, OBGYN, family doc, a midwife, or a nurse took a peek at your genitalia and decided to name you either a boy, a girl, or something that required a little more study. Or if you were born more recently or you had any complications during your pregnancy, you might have had a karyotype done, which is essentially a picture taken of the genetic material. And so a doctor might have taken a look at that and seen two X chromosomes, which would then label you a female, an X and a Y chromosome, which would label you a male, or a variation. And there's a lot of different options out there beyond just XX or XY. And so depending upon your karyotype and the genitalia you were born with, you were assigned a sex at birth. And so the options traditionally are male, female, and then intersex or different sexual development, which encompasses all of this territory between the two, male and female. So even sex assigned at birth is a lot more complicated than we give it credit for, but sex assigned at birth is all about body parts, and gender identity is all about how you feel inside. And so it's often the case that your sex assigned at birth and your gender identity line up perfectly. So if you are assigned male at birth, you might identify as a man inside. And in that case, because both of those things line up, they are on the same side of the male-female spectrum, we would identify you as a cisgender person. Cis meaning same, that your gender identity and your sex assigned at birth line up perfectly. But if, like me, the sex that is assigned to you at birth is not on the same side of the equation as how you identify inside, then you would be labeled a transgender person, trans meaning opposite. So the sex that was assigned to you at birth is just not the same as how you identify inside. So for example, in my case, I was assigned female at birth, but I identify as a man, and so I'm a transgender man. If someone was assigned male at birth and identifies as a woman, they might identify as a transgender woman. There's a lot of different variations, a lot of different terms that people can use. There's also folks who don't identify as either gender, and so would describe themselves as potentially non-binary. But all of these concepts would fall under the general heading of transgender because the sex assigned at birth and the gender identity do not line up naturally like a cisgender person has, and so they would fall under the transgender umbrella. So those are two main concepts and most of what we're going to be discussing today. But the third concept is sexual orientation or sexuality. And this concept has nothing to do with who I am personally. It's all about whom I'm attracted to, either romantically, sexually, or both. So it's kind of your pattern of attraction over your lifetime. And the terms that people might use to describe their own sexuality are things like lesbian, or gay, or bisexual, or pansexual, or straight, and all of these are terms, and many of which are evolving to describe how we feel about other people. So when we started, I identified as a queer trans man, which is a longer backstory, and if you want to ask, you can, but essentially queer means that I'm not straight, I'm something other, and I don't need to define it further for you. It's got a little bit of a political edge to it sometimes. So those are all the terms that we're going to just talk about today, and I want to make sure that everyone is really comfortable with those things. So gender identity, who I am inside, sex assigned at birth, the sex that was assigned to me when I was born, and then sexuality, who I'm attracted to. Three really important concepts, and we knocked it out. So the next thing that I just want to mention is that even if you are a provider who does not think that you have any transgender patients in your practice, this is still very important for you to know, because trans people are certainly starting to come out of the closet, starting to show up in doctors' offices more frequently. And just because someone hasn't come out to you does not mean that they are not identifying as something other than cisgender. And so it's really important that at the very minimum, all medical providers are comfortable asking about gender identity, asking people, how do you feel inside? Do you feel like a man? Do you feel like a woman? Do you want to talk about your gender identity? And just start that conversation and revisit it from time to time. Just like we are starting to more broadly ask questions about sexual orientation, not assuming that everyone is straight or heterosexual, but asking people to whom they are attracted. So a similar concept applies with gender identity, and it's important to become comfortable asking those questions. The reason it's so important is because we now have data to prove that not asking these questions can be really detrimental to a person's health. So we know that there's incredible health disparities affecting the transgender population. So the latest big study was in 2015, the National Transgender and Gender Nonconforming Survey. And it showed that an incredible number of transgender and gender nonconforming people were not only harassed when they went to seek medical care, so 33% of all of the people that responded said that they faced some sort of negative response when they went to seek medical care, including either physical assault, verbal assault, sexual assault, or being refused care on the basis of their gender identity. But in turn, that 33% of people who experienced that were less likely to seek care the next time, even when they knew they were sick or needed care. So another statistic from that study is that 23% of all transgender and gender nonconforming individuals said that they would not go seek medical care even if they knew they were sick, because they were afraid of the harassment they were going to face. And so it's really important that we're asking patients about their gender identity, we're asking in an open and honest way, and that we're taking care of all the patients that come to our office regardless of their gender identity. So that's my little preamble, that's why it's important, and that's what those concepts are. But I'm also happy to take any questions that might happen now. So do we have any questions?
Sure, Dr. Kyan, we have one question here. The question is, how can providers talk to their trans patients about their bodies in an affirming way while still getting the necessary medical information?
Right, so this is a question I get a lot, because I think medical providers are a little uncomfortable talking about gender identity, but they are very comfortable talking about body parts in what are traditionally gendered terms. So talking about women with uteruses, or talking about men with prostates, talking about different body parts in terminology that trans patients might not be comfortable with. And so the first thing to do is just have a conversation about that, to say, you know, I know that you're a little bit uncomfortable potentially with some of the body parts that you have. I see you as a man regardless of the body parts you have, or I see you as a woman, or I see you as non-binary regardless of what body parts you happen to have. But my job as someone who's in charge of your health care is to make sure that I'm taking care of the body parts that you do have. And so we are going to need to talk about those body parts. But in order to make this comfortable for both of us, I want to use the terms that you're most comfortable with. And so opening the conversation, opening the door, allowing your trans patients to tell you what words they want to use when they're talking about the body can be really useful, and really just a gesture showing that you really do see them for who they are and that you really want to make it as comfortable for them as possible. So some examples: instead of giving a trans man a breast exam, you might suggest that you need to do a chest exam. It's a simple change of phrase, but it can make a huge difference to your patient. Similarly, instead of saying we need to do your pap smear or your prostate exam, we can say that we need to do your yearly cancer screening, or your every 3 or 5 years according to guideline cancer screening or internal exam, and just take the gender terms out of it and remove some of that discomfort for your patient.
Okay, thank you for that. So we have I think we can just take maybe one more question here due to the time constraint. Is hormone replacement therapy, testosterone, estrogen, effective birth control?
So this is a question I've gotten a lot frequently, or actually a question I've teased out from people who thought otherwise. So there's very few data on all of this, on hormone replacement therapy generally, but what we do know is that testosterone, when used for trans guys who still have a uterus and ovaries, is not effective birth control. So if you are a trans guy and you are on testosterone, if you still have those reproductive organs, then you are still capable of becoming pregnant if you have penetrative sex with someone who produces sperm. So testosterone is not an effective form of birth control, and it's important that your patients know that, and that we're offering real comprehensive care. Same thing for trans women who are on estrogen. While estrogen will make it much less common to have erections, if you can produce an erection and you have sex with someone who has ovaries and uteruses, you can still lead to a pregnancy. So it is not an effective form of birth control for either trans men or trans women, depending on the person taking testosterone or estrogen. And so it's really important that we're talking to our trans patients about birth control and contraception beyond just the hormone replacement therapy. So I think that's all the time we have. If you have any further questions, you can always reach out to me through the Clinical Education Initiative, which is what's bringing you this video today, or through my website, thequeerhealthguys.com. Hopefully see you soon. Bye.